So I have two cases for you guys today. The first is a child. It's a 7-year-old female with a history of eczema as an infant, wheezing until the age of 3, who comes in with recurrent acute onset wheezing. She has a dry cough but doesn't have any other symptoms. No shortness of breath, no dyspnea on exertion, no fevers, no chills, no sputum. And she's playing normally. But has had 2 similar episodes a year which require albuterol and occasionally oral steroids, and doesn't have any allergy symptoms. She has a strong family history of allergic rhinitis and asthma, but otherwise is unremarkable. On exam, she's got allergic shiners, boggy nasal turbinates. She's got significant amount of mucus. She has a nasal crease and lots of drainage in the back of her throat, and her tonsils are big. And so she came in from another allergist, and she had testing done before, and she had significant positives for trees, grasses, molds, and dogs, and negative for some others. She's a normal chest x-ray, and we'll talk about nitric oxide in a minute, but we did do a nitric oxide test, and it was elevated, and her pulmonary function test was essentially normal. So what is the next best step? Is it to start inhaled steroids, stop peanuts and give an EpiPen, start antibiotics, or remove tonsils? And we'll come back to this. The second case is a 6-year-old obese, non-smoking male who comes in with nasal congestion, a tickling sensation in his throat, cough, and wheezing for 6 weeks. He also has some dyspnea on exertion and no other symptoms. It happens mainly in the day, but also at night. Has tried albuterol, has tried various over-the-counter medicines, takes nose sprays and antihistamines, follows everything that we've asked him to do, has tried albuterol without relief, and has tried inhaled corticosteroids and LABAs, I think it was Advair, for a past history of asthma without any relief. He does have allergic rhinitis, acid reflux, anxiety, asthma. He's pre-diabetic, and he does have heartburn symptoms multiple times a week. He's on multiple medications, including allergy medicines. He was on a proton pump inhibitor but stopped because he felt bloated. And on exam, he's obese, and he's got significantly swollen turbinates in his nose, and he's got some drainage in his throat. So he has never had allergy testing, and his breathing test is normal. We also did a nitric oxide test, and his level was normal. So what is the next best step? Is it to try another steroid, treat him for acid reflux, start antibiotics, or stop the medications due to a medication side effect? So this talk is about chronic cough, and it is the 5th most common symptom presenting to the primary care office, and it is a big industry. Over-the-counter cough medicines cost $1.6 billion a year. And if anyone has ever had a chronic cough or seen a patient with chronic cough, you know that it is a pretty frustrating symptom to have. It causes a lot of anxiety. It causes people to avoid many social situations. They don't want to go to work. They don't want to go out to eat. It's a very, very frustrating symptom to have. They lose sleep. They're less productive at work. And they usually are very tired because they're up all night coughing. So what is a chronic cough? So an acute cough is a cough that lasts less than 3 weeks, and it's usually about 8 days. And this is usually due to some upper respiratory infection, a sinus infection, or bronchitis. Subacute is between 3 and 8 weeks, and that's usually a post-infectious cough. And chronic is lasting more than 4 weeks. So most people think cough really is just a symptom that's originating from your lungs, but it takes a lot of structures in your body to produce a cough. It involves your brain and several nerves that are located in your throat, in the back of your throat, your trachea, your airways, and even your diaphragm, which hits your stomach. But you have many structures, so coughs don't have to just originate from your lungs. They can originate from your nose, your throat, and even your stomach. So the most common causes from age 3 and up, it's mainly postnasal drip, asthma and bronchitis, or acid reflux. And oftentimes you have multiple of these conditions occurring together that can be very, very frustrating. In smokers, you also have to think about lung cancer and COPD. And in infants and toddlers, you should also be thinking about structural defects, things like foreign bodies as well, if they ingest anything, and things like cystic fibrosis. Okay, so the differential, I would think of the ABCs. Aspiration, birth defects, cardiac, if they have heart failure or any other sort of like aortic stenosis, valvular diseases. Compressive, if you think of your thyroid, if they have a goiter. Defective mucus clearance, like cystic fibrosis. Environmental lung disease, allergic asthma. Foreign body, granulomatous disease, like sarcoid. Acid reflux, hyperactive airways, and infections. So the number one cause is postnasal drip. Oftentimes people have thin, watery, runny mucus that either comes out the front or goes on the back of their throat. If it's infected, it's usually yellow-green. It might be thick and sticky, so it's a little bit different. But oftentimes they present with a tickling in their throat, or they feel like there's something stuck in the back of their throat. And it's often worse at night. And there's many, many causes, and these are just a few. But allergies, infection, pregnancy due to hormones, especially in the second and third trimesters, cold air, humidity, foods, and structural abnormalities. Something else to think about is that as we age, our nose loses its ability to function, and so you'll often see, a 60-plus-year-old male or female who just says that my nose drips all the time, and so that's pretty common as well. Diagnosis is mainly clinical, and you can just empirically treat. You can try like neti pots, nose sprays. Anticholinergics work really well to dry up drip, and that's usually what I use for my elderly patients, like Atrovent. You can also try some decongestants. I know Dr. Ramey's spending a lot of time talking about asthma, so I'm not going to spend that much on this, but like he said, there's multiple forms of asthma, and so they don't necessarily have to present with wheezing, dyspnea, exertion, or shortness of breath. They can just present with cough, and oftentimes it wakes people up in the middle of the night. The hours of 2 to 4 a.m. seem to be where cough variant asthma occurs. It can be triggered by environmental allergens, pollen, dust, mold, cold air, and even exertion. And to diagnose, as Dr. Ramey had mentioned, it can be pretty tricky. You can try, various testings, but if you've ever tried to test a child under the age of 5, it can be pretty difficult. And then there's acid reflux. And how does this occur? It's often cough without wheezing or shortness of breath. It usually occurs at nighttime or after meals. And it can be associated with symptoms like heartburn, a metallic or bitter taste in their mouth, bad breath, but it is oftentimes asymptomatic. So what happens, and this is how I kind of explain it to my patients, is that you have reflux that comes into your throat, and it's not supposed to be there. So your throat sends a signal to your nose and your brain to say, hey, come protect me. And so your nose then sends mucus on the back of your throat, and your throat doesn't like that either, so it tries to get that out, and you end up coughing to try to get rid of that. So acid reflux, if it's asymptomatic and it's causing your cough, can be very, very annoying. How do you diagnose this? Like any other way that you diagnose acid reflux, you can do endoscopy, or you can just treat them empirically. Lifestyle modifications, one of the main things is to lose weight. Many of these people are obese. But also to avoid hot, spicy foods, limit caffeine, limit alcohol. And so the other way that that acid reflux does cause cough is because if you have increased abdominal pressure, and these are usually your overweight people, it triggers a nerve near your diaphragm, which also increases the reflux content into your throat, and it lowers your cough threshold. So the other thing that we have to keep in mind is that many of our patients are on multiple medications. And many of these people, if they have high blood pressure, are often on ACE inhibitors. And 20% of people on an ACE inhibitor will have some form of cough. And usually it starts with a throat tickle and then can move on to a dry cough. It occurs within 3 weeks to 1 year of starting it, but can occur afterwards. So stopping ACE inhibitors is usually a good step, and using alternatives. But there are other medications that can cause cough. And so commonly, and we don't think about this often, but birth control pills can do it, as can other cardiac medications. So what to do next? So, there are some things that we all can try, which is, stop smoking, stop your ACE inhibitors, treat for various conditions. But then if you look down, some of the testing that is recommended are a little bit more invasive, bronchoscopy, echoes, high-resolution chest CTs. They tend to be more expensive, and oftentimes they come up normal. And so if you go through a whole workup for cough and you end up with normal testing, your patient is going to be very upset. It's probably cost them lots and lots of money, and they still don't have an answer. So what should you do? So, and then on top of which, oftentimes with cough, you have the same characteristics. You can have dry coughs for all of the 3 most common causes. It can be triggered by the same thing. It can be worse at night. You can have normal test results. Your spirometry can be normal, and your treatments that you try are all very varied. So what do you do? So this is what I think Dr. Ramey was alluding to earlier, is an exhaled nitric oxide test. And this is what the devices can look like. They're very small, they're portable, you can take them in and out of patient rooms pretty easily. So what is exhaled nitric oxide? So when you have healthy tissues, your body, your lungs do produce some form of nitric oxide, but not that much. And when you have inflammation of your lungs, which is what happens in asthma, you produce more of nitric oxide. And that is something that inhaled corticosteroids helps downregulate, because it helps knock out those inflammatory mediators. So you get better, when you use inhaled corticosteroids, you actually get better ventilation of your lungs, because it's shifting from removing the inflammatory component of the asthma, and you get better response to treatment. So what does this do? It measures the level of nitric oxide in your breath, and it helps to diagnose and treat asthma. So normal is below 20 and 25 in children and adults respectively, and abnormal is above 35 and 50 in children and adults respectively. And it's really useful to diagnose or to distinguish different forms of cough. And like Dr. Ramey said, it is a good lie detector test. You can determine if someone is actually adherent to their treatment. It can also help predict if they're going to relapse if you start keeping track and monitoring the levels over time. But the problem is that you can also have a lot of skewed values. If you eat something that's like a smoked meat or something like that before you do it, if you take medications, if you're a smoker, if you've even recently used your inhalers, that can all vary the test results. So, so how do you prepare for this test? Usually we recommend to avoid for 2 hours before the appointment to using an asthma inhaler, eating and drinking, exercising, and using any sort of tobacco product, toothpaste, or mouthwash, because those all will negatively affect the test. It's also very easy for kids to do. I don't know how many of you have tried doing spirometry on a child less than 5, but it's virtually impossible. So most of these kids, especially the 5 and under group, can do this test pretty easily. So what are levels? So it really helps determine if you have any sort of allergic or eosinophilic component that is causing the cough or other symptoms. And so what I like to look at this is if it's low, below 5, or if it's above, that's when you know you need to act pretty quickly. So usually if it's below 5, you need to consider things like if their cilia are actually working correctly, or if they have any form of chronic lung disease or cystic fibrosis. If it's higher than 5 or higher than 50 or 35, you need to think about whether they're actually taking their medications, whether is their medication enough. And now we actually have newer therapies, which I know that Dr. Roop is going to be talking about, that actually they're biologic therapies that help decrease the inflammatory components and the eosinophil counts, like Xolair and Nucala. So with our first case, there's a 7-year-old female who had a chronic cough and wheezing. She had allergic rhinitis, and she was positive to multiple environmental allergens and was responsive in the past to steroid and to albuterol. She had normal pulmonary function testing, but an elevated FeNO at 55. Normal for children is below 20. What is the next best step? So should she start an inhaled corticosteroid, stop peanuts, start an antibiotic, or remove tonsils? So the answer is to start the inhaled corticosteroid therapy. In the second case of the 60-year-old obese male with a history of asthma and acid reflux who presented with chronic cough without wheezing, and who does have heartburn symptoms, who was not responsive to any of the prior therapies, had normal spirometry and a normal FeNO, what is the next best step? And in this case, it would be to treat the acid reflux, start lifestyle modifications, and consider antacid therapy. And that's it. Any questions? Yeah, so singular, in my experience, singular, it does help, as a leukotriene antagonist, it does help bring down some of the allergic component of cough and asthma, but does it work all the time? No. So usually I see it's about 50-50. 50% of the time it works and 50% of the time it doesn't. It's also associated with some side effects. So for kids, if they have behavior problems, aggression, bedwetting, nightmares, night terrors, that can be an issue for parents. So I usually have to weigh out the risks and benefits. But it is a good option, especially in your young patient population, because it is approved for age 1 and up. Any other questions? Mm-hmm.
What medicines or food will give you a false positive nitric oxide?
A lot of the smoked meat products can do it. Cheeses, actually some fruits and vegetables can do it too. So pretty much anything that's unhealthy can do it, pretty much. Mm-hmm.
So after looking at your diagram,
Mm-hmm.
and of course at the bottom when you go through all the diagrams
Mm-hmm.
of testing, you end up, and everything's normal, you end up with this cough, hypersensitivity syndrome.
Yeah.
Can you tell me a little bit about what you do to treat those patients?
So usually you have to look for, once you've exhausted all your other causes, usually I try to treat, usually we use, I can't think of the word right now, medications that are more neurologic in nature. I usually refer those to a neurologist to try, and that, if you block things that can block the vagus nerve, usually help with that.